Now, maybe you know the answer to this, lickety split right away. That's okay, and that's great. If you're in the test, any kind of test, and you get a question, you know the answer right away, awesome. You just saved some of that 60 seconds for another question. So don't feel guilty or that you have to spend 60 seconds on every question, but make sure you know you haven't missed stuff. So go through your rubric with every question so that you aren't tricked because you didn't go through what your rubric, your system, however you do that. Deliberately think through each one of these practice questions. Do this today so that you build that and then you can get better at it. So that baseline, knowing how to work, how to approach, how to do medical tests the way you do them. I'm showing you a way, but you develop your way from this. And then once you got that base and that skeletal structure underneath, then you can play jazz with it, and then you can go through it. So learn your chords, do your scales. So what is this question? So it's a little bit back, it's not straightforward, is it? This is a treatment question. Yeah, but it's asking you, it's giving you the treatment and asking you a diagnosis, right? So plan of care is also encompasses more than just first line man or initial treatment. So it could be something else. So remember, just think about how the question's asked, what's asked of it, and this one's a little different. And fair game on how this is asked. Just so you know, every test at IPAP, we're only allowed 2 negative questions. If you know that, how that works, which one of these is not? That would be a negative question. So we're only allowed 2 of those per test here at IPAP to train you to think in the positive. And I try not to do any, but if you see one, I'm allowed to, so give me a break. All right, what kind of med is propranolol? One, before we say the class, is it upper or downer? Downer, good. What kind of med is, what class of med? Beta blocker. What's primary, what beta blocker is used for? Blood pressure, hypertension, right. And then we pull it over into psych for what? The downer part, right. And when you think propranolol in psych, what comes to mind first? Say again? Disorder, good. What kind of disorder? Anxiety disorder, yeah. And how would you use propranolol? Would you use it chronically once a day all the time? Or would you use it PRN? PRN, good. And when would you use PRN? For what? You said anxiety, but what kind of anxiety? Predictable anxiety, all right? So that's what, if you think of psych, if they gave you this psych question, you think propranolol, you should think predictable anxiety, PRN, for propranolol, right? That's the first top of the list. Now, if we got a comorbid something, if you're out of the pants and they blend diagnoses and say which of these 2 diagnoses were best treated by one med, right? Then you want hypertension and predictable anxiety. That would be a marriage made in heaven for propranolol, right? So think about that comorbid, somebody with low blood pressure, we might not give propranolol. Careful of that, right? If they give that to you intentionally in the question and they're asking you to give you something that would lower it even more, careful, watch out and see if there's a better answer. Good. So what kind of diagnosis? Too excited, said anxiety, good, predictable. What kind of anxiety is predictable? Social anxiety. What is social anxiety? Fear of group speaking in public. What do all those have in common? Being judged, being scrutinized by others, right? So the fear of being scrutinized by others. Good. Social anxiety. That's the hallmark of that. All right. So let's look through these diagnoses or conditions that we see if it fits. Social anxiety disorder. Boom. There it is. We like that one, right? Marked fear of anxiety about one or more social situations in which the individual is exposed to possible scrutiny by others. You know, that fits propranolol. Examples include social interaction being observed performing in front of others. Yeah, that sounds good. Does the question, when it's saying propranolol, add propranolol, does it specify QD or PRN? Nope, that's shooter's choice, right? If you add propranolol without stipulations, then you get to choose. So think about how that's asked. If it says add QD propranolol, plan of care, then that'd be a different question, right? We'd be looking at a different, but it just said add propranolol. It fits. Let's see if there's a better answer. Oppositional defiant disorder. What's the first line of treatment for ODD? Remember what's the hallmark diagnostic criteria element of oppositional defiant disorder? Defying authority. Good. So what's the first line of treatment for defying authority? I appreciate my saying Muhammad Ali right there, but there's actually something different for ODD. Yep. Phone friend. Yes, behavioral, parent. What do you call that? When you enter into those arenas of their life, both their mind and where they live. Psychosocial intervention, right? So you try to help them think about it one way, and you help the family and those that are the world they're in deal with it. So psychosocial intervention, right? That's number one for ODD. For defying authority, we want psychosocial intervention. Good. Now, we said propranolol is a downer, and it's PRN. We could give PRN. If somebody's defying authority, do you want to give them a downer? Yeah, we want to give them the forget-me-stick, don't we? Don't do that. So, treat comorbidities is where pharmaceuticals come in to ODD. Treat comorbidities where appropriate. That's when we use medicines for that. And so be careful, because ODD usually, it doesn't have to be kids, but usually it's kids, and somebody of the kids usually doesn't have hypertension, right? Or social anxiety. Is this better than social anxiety, ODD? I don't like it. I don't like it better. How about substance-induced anxiety disorder? What's the main treatment for substance-induced anxiety disorder? Remove the substance, yeah. So stop it. If y'all watch that video, stop it. Don't add another substance to a substance use disorder. You can just remove the substance. That's step one. All right, elder emotional abuse. What's the treatment plan for that? Intervention, right? We're not giving meds to an old person to further down them when they're probably down about being abused. We want to intervene. Intervention, safety eval, report to authorities, maybe. Abuse, we're mandatory reporters, remember that. Support them, support their caregivers, connect with the resource, educate, look out for the caregiver, make sure they're doing okay. Add propranolol to that? Probably not. All right, interpersonal violence. What is interpersonal violence? Think about what the words mean. Violence, domestic abuse fits into that. Violence between people, right? When it's violence between people, somebody before 18 years old, what do we call that? Child abuse, usually, and that's the big jacked 17-year-old, right? Doing that. So child abuse before. What about elderly violence? Elderly abuse usually fits in that. Anything in between, we would say interpersonal violence or domestic violence, yeah. But do we add propranolol for that? Well, that's pretty similar to elder abuse. We don't want to add a med, a downer. We want to do other things. Good. Nice, good job. PRN, there it is from our slides. Social anxiety disorder treatment preferred when it's PRN, when it's predictable. There you go, from specific phobia treatment when it's predictable. Another one could be. I know I'm going flying. I know I'm going into the MRI too. I know I'm going to be going to this place, Alaska, with all those mosquitoes. Just kidding. Propranolol. Don't get somebody Alaska mosquito. Oh, Minnesota. Those mosquitoes will carry you away. Air traffic controllers. There it is for panic disorder, predictable. Generalized anxiety, Lewis. It's down way low on the slide for generalized anxiety. Why is that? Why isn't it up there to say everything? Is that predictable if you're nervous, worried about everything? No. We're not going to give it to them QD all the time. just to keep them down. We're gonna do other things, yeah. Good. PTSD could be for peripheral. What's the only class of med indicated to treat PTSD? SSRI, good job. That's the only class of medicine indicated to treat the underlying condition of PTSD. Are there other meds that can treat peripheral symptoms of PTSD? Yeah, there's a lot. Look at that list. There's a lot. Prazosin famously for nightmares, could be in there. Trazodone for sleep, but that doesn't treat PTSD, that treats a symptom. Make sure that's straight in your mind. Symptom versus underlying disorder. Good. All right, second question. All right, what's the question? Good. Best treatment for most likely condition. All right. So one, we gotta feel like what's the smell the most like. Make sure we know what diagnosis we're treating, and then best treatment for it. So we don't know acute, chronic. We don't know what the diagnosis is. So we gotta read the stem. Right. So is this an adult or child? Adult. Male or female? Male. How long has this been going on? Why is he here? Anxiety and worry. Right. What else is going on there? Before losing his job, I appreciate that. That's part of what we're looking at. What's that list of stuff there? What does it smell, sound like? Generalized anxiety. I like that. Why? What's in there that may think you, ooh, shoulder tightness. Remember that? That's it. That's unique to generalized anxiety disorder, muscle tightness. Okay. What do you think? Is it better or worse? Same? Worsening. Okay, so that means we got to do something about it. So best treatment isn't watching weight. It's getting worse, so we got to intervene. We got to do something that's not already there, or crank it up. All right, his wife's there with him today. Supportive. Is that a good thing? Nice. Okay. But asked him to make his appointment because it's getting more difficult to deal with his trauma. So she's there. She's being honest with him. This is a good thing, right? It's a good thing. It may be tense in the room, but she's looking out for him, trying to get that. And be honest, he probably has got some drama going on. If you lose sleep, we all get a little cranky, right? So at risk, you said risks of what this is affecting him, spilling out over in his life, what's going on there? His job, right? His job. Remember what condition is from block 1, where job is a big motivator. Alcohol abuse, good. It's also a motivator in other things too, but that's a good one. So job, now it's important. Can't get that coin, can't get paid. It's getting there. Mom needs new shoes. He appears anxious and tired in your exam room. All other exams and workup are earned. What does that tell you? Organic ideology is off the table. Thank you. Question. So now we're dealing with what's given to us here. We don't have to go hunting. It's here, right in front of us. So you think it's what? Generalized anxiety. And what do you start with that? SSRIs. Good. So why not give him benzo? Because down anxiety, quell that anxiety. Why not give him benzo? Right? Long-term effects, long-term, you just create a junkie, right? Yeah. So what is Zolpidem? Sleep med, good. What is it? What kind of medicine is it? It's a non-benzo, benzo antagonist. Yep. So it's not a benzo, but it acts like one. Helps you with sleep, good. Getting to sleep primarily. Yeah, good. What is atomoxetine? Stimulant, yep. Or a what? What do we treat that for? What do we treat with this? ADHD. Is it a stimulant? Non-stimulant, but it treats ADHD. Good. Propranolol? downer, right? So the maybe. So the best treatment so far, is that the best one? I think so far. That's the best one, yeah. High paroxetine. Downer, SSRI, sedating, fat lazy period. All right, so there's our SSRI. That's better than propranolol. Good. All right, next one, sertraline. What is that? Oh, snap. We got 2 SSRIs. Dang, we got sedating and inactivating. So which one is best for this patient? You want a sedating one? Why? Okay. Okay. What if it's activating, and if he wakes up, then he'll be better during the day? And I can see y'all's mind doing that during the test. Don't go there. Let's get insomnia, can't sleep, let's give him something to sleep. Paroxetine. There's a generalized anxiety disorder. Good. That's what showed up in the question. There's our pink box. Good. Good. CBT is first line, but that wasn't a choice. We were wanting CBT to be there, right? Because we didn't see that in the question. You hadn't tried that yet. SSRI. Insomnia. We want something to help him sleep because he's not sleeping. Have him take it neat. Dose of neat. Good job. Nice. Next question. Oh, what airframe is that?
A10.
A10. Sound free. So what's the question? Asking for a diagnosis, right? So there's criteria. Diagnosis is a technical word. So there's criteria for a diagnosis where there's symptoms and we count them and there's time criteria, but it says most likely. So that'll tell us maybe you don't get all the ingredients, which one would be closest to baking the cake, right? All right, so who we got? Child or adult? Child. We're assuming we're talking about the grandson so far, okay? Male or female? Male. Where are we? PCM, so we're stable or unstable? Stable. How is he there? Grandma brought it. All right, what do you think about that? Grandma brought it. It's not a, I know it's kind of a loose term, but traditional family. Grandma, there's a little something there. He may have a little bit of history in the family to deal with, so there may be, we don't know the drama behind that, but just know it's not mom or dad. Does grandma bring it? Okay, noted. Why did she bring it? Compliance with whom? Teachers, authority figures. Ooh, what's that sound like? Remember that slide with the little girl breathing fire and mom and dad? ODD, yep. Defying authority, is that what that sounds like? What's the next step up or in severity from ODD? Conduct disorder. What is conduct disorder? What does it typify? How would you describe conduct disorder? Jason Dunn, serial killer in training, right? I like your hand motions there. It's badness, right? Illegal activity, torturing animals, deliberately infringing on the rights of others on purpose, doesn't care. Cold, calculating, emotional dysregulation is not a part of that, doesn't have to be a part of that diagnosis. This one, do we see illegal activity? Do we even see truancy? You know what truancy is? Skipping school, do what I want, smoke cigarettes out back. All right, we don't see that. We're just seeing defying authority, right? Is it affecting his life? Is it spilling over? Is it clinically significant?
Yes.
Yep. Grades, right? Grades are deteriorating. Maybe he don't care. That's how he is, don't judge him. Struggling dealing with him, grandmother, another form of authority, right? So not just school, but at home as well. Remember what this one has to be, not just in the presence of, but doesn't disqualify you, but it has to be someone other than a sibling, right? If it's with a sibling, that doesn't disqualify them, but it has to be also with somebody else. And we think about an older sibling that would maybe fill the role of a parent before they get home from work or something like that. They're the ones left in charge, and they're defined against that. Good. Resents having to live with her. No indication of a learning disorder. What does that tell us? Not ADHD or autism, neurodevelopment. Good. So that's helping us. Organic ideology off the table. Nice. Good. Now, before we look at this, what else do you want to know about this relationship that's sitting in front of you? Is there child abuse? Is she the primary care? What's going on here? Does he have a legitimate gripe? Is she got the iron fist too tight because she's scared of letting that go and being too loose? Or that's how it was when I was young, and you get a beating when you don't make your bed, whatever it is. Maybe there's something else that's going on from the other side. We don't see that in the question, but just for your clinical gestalt, you don't want to just turn all your attention to the grandson and bring down the thunder on him and not ask grandma, tell me what's going on, and help her and say, you know what, we got some people that can help you when you're at your wit's end dealing with your grandson. There's some other people who've been in a similar situation. We have professional counselors that can help you give some tools to do. So approaching it from both sides so you protect your patient, who in some ways can't protect himself. He's not autonomous. He's not 18 making him 19. Making his own decisions. So looking at it both ways. But in this question, we're just talking about the grandson. Good. So we're looking at diagnosis. Let's work our way through this. Adjustment disorder with depressed mood. One, have we talked about that in this class? Sorta. Yeah. That is a technical diagnosis. Adjustment disorder with depressed mood. So far, it's the only option we got. And let's look and see. What is adjustment disorder? What does it need? Number one, what do you have to be exposed to? A change, a stressor. What is a stressor a lesser version of when we think about what lecture we're thinking about? Trauma. Not a trauma, but a stressor. What's an example of a stressor? iPad. Agreed. What else? Job. Change in living situation. PCS. Yep. Breakup. Girlfriend. Boyfriend. Yep. Something like that. Life change. Something happened. A stressor. Yep. And then, when does it have to begin? The symptoms. Right away? Within 3 months. Why 3 months? Why do you get that whole? We broke up 2 months ago, and now I'm gonna sit there. Say, I think you heard. I think you said it. Honeymoon phase. Yeah. You thought that was a good idea, but after a while, you think, oh, maybe that wasn't a good idea. I took this job. It's not what it turned out. I thought it was not as advertised. Good. And so when does adjustment disorder need to be resolved by? To keep calling it adjustment disorder. 6 months. Yep. So it's a short-lived thing. And if it gets beyond that, what do we call it? Unspecified anxiety. Good. Unlikely, right? Based on, and I can't give you that, based on what kind of timing do we have here? Do we have time?
Past year.
Past year. All right, so we're over 6 months, so we can't call it adjustment disorder. All right, ADHD, what do you think about that? Say again. He's already done the learning disorder, been rolled off, that's the learning disorder. Off to conduct disorder. We kind of talked about it already. Illegal stuff, nope, don't see any cruelty, cold, calculating, patient, predatory. How about factitious disorder imposed on another? Who's our poster child for that? Gypsy Rose and Mama Dee Dee. do you think grandma is imposing this on the grandson and saying, my grandson is sick, so I get the attention, I get to be cared? It sounds like what we're given, she's actually struggling. Hey, fix it, because I don't want to do it. Good. How about oppositional defiant disorder?
Yes.
Sticking with it? Okay, good job. There's our criteria. A lot of emotional dysregulation in these diagnostic criteria. Good. Oppositional, argumentative, defiance in the name. There you go. Distressing the self and others, negatively impacting. There's the pink box. What do we do for it? Yeah. Psychosocial intervention. Good job. Psychosocial intervention. If we get the conduct disorder, this is talking about conduct disorder, why do we think about SGAs and conduct disorder?
I want to read this line.
I mean, yeah. You're saying it from memory though, because you know.
Yeah, there's typically more aggression.
More aggression, right. And we want to intervene sooner rather than later, because what does this grow up to be? Antisocial personality disorder, which is good guys or bad guys? Bad guys. We don't want to make it bad guys, so let's stop the bad guy. And so we give a big gun right out of the gate, SGA. And which ones in kids do we rack our brains with? Maybe give them that. Spiridone. Yeah, practice saying it. Aripiprazole and quetiapine. So it doesn't stumble off your tongue with a patient and they go, first time? Good. There they are from the med slide. Good job. Rack your brain trying to figure out how to control assaultive, aggressive behavior, conduct disorder. Next question. All right, what's the question? Most likely condition, good job. Is this adult or child? Adult, male, female? Stable or unstable?
Non-stable.
Where are we? We're in the ER, and how do we get there? Law enforcement, cuffed and stuffed him, brought him there. And what does this sound? What lecture are we in? What do you think? Psychiatry, good. We're in the class. Good. More specific, you said. Forgive me. Couldn't pass up a dad joke. Yeah. What lecture are we in? Schizophrenia, which is the hallmark of schizophrenia is what? What medicines do we use to treat schizophrenia? Antipsychotics, so psychosis, right? Psychosis. What are 3 positive symptoms in psychosis? Hallucinations, delusions, disorganized speech. Yep, good. Something that's added, something plus, a positive symptom, not in a good way, but something that's additional or added to. So those are positive. So we're thinking schizophrenia. Is that what you're thinking? That realm, that family? Good. Agreed. All right, so what do we got here? Do we have a time component? Yes, what do we got? 8 months. So schizophrenia, you remember we have a spectrum. We grow up into those things into 3 different diagnoses. The first one is, how long is that one? 1 day to a month. What is that one? Brief? Psychotic disorder. Good. Brief. And then next one, a month to up to 6 months. What that was called? Schizophreniform. Schizophrenia not yet. Hadn't formed yet. Schizophreniform. So it's got all the criteria of schizophrenia, but it's not time, hasn't gone. So 6 months and on, criteria A, which is schizophrenia, and the time, schizophrenia. All right, so we're in 8 months. So in the schizophrenia world, we're talking about schizophrenia. Right, so now let's see if we got what we need here. So we need a positive symptom. How many of those? So we have a choice of 3. How many of those do we need?
One of those 3.
One of those 3.
One of those 3. 2 overall.
2 or more symptoms. Yep. 2 or more symptoms. Let's get to it. Let's look at it, what we're talking about. 2 or more symptoms. One of them has to be a positive symptom. There it is. Why can't disorganized speech, or in whom is disorganized speech not an option? Autism. Why? Part of the diagnosis. We don't want to misdiagnose with something else. Good. Let's walk through the other ones just to give it. We said brief. Good. Delusional disorder. Do we have delusions in this one? What's the delusion? Which one is the delusion? Okay. What? Give me a short definition of a delusion. Fixed false belief. So is there something in here that tells you he's convinced of something? What is he convinced of?
Can't cross this bridge.
Can't cross the bridge, okay. I appreciate that. Now in delusional disorder, what else is present? What can be present in the psych world or in those to still be delusional disorder? Is it possible to have something else, or is it just delusions? Just delusions. That was a poorly worded question. Only delusions in delusional disorder. It's not hallucinational disorder. It's delusional disorder. Only delusions and delusion. What's the time commitment? What's the time criteria for delusional disorder? Only one delusion, 1 month. Delusional disorder. Is this the only problem he's got going on? Is the troll on the bridge? Nope, he's got other problems going on. Yeah. You don't get cuffed and stuffed and brought to the ER if you just have, if you're trying to answer a riddle. Right. That is iPad. All right, schizophrenia. All right, let's look at 6 months, yes. Delusions, we said yes, that's there. Are we having hallucinations? What is hallucination? Help me understand. Tell me what a hallucination is. No stimulus, but what is present? A sensory impression. So taste, feel, smell, sound, and what's the name? I don't know, something else. One of the other senses. Clairvoyance? ESP? Oh. So if they're having that with no stimulus, that's a hallucination. If they see something that you don't see, if they smell something you don't smell, if they hear something you don't hear, that's a hallucination. Y'all watch that video of the guy smoking a cigarette in the phone camera? If you want to see that, he's describing that to you and saying, right now I'm seeing this. And he's looking around and there's nothing there. And he understands that. He's self-aware, but he's telling you what he sees. If there's nothing there for us, that's a hallucination. Good. Disorganized speech. Do we see that here? Yeah. What is it? Non-stop gibberish. Right. Now, what other diagnosis might we start thinking about when we think of speech and talkative? Mania. What's our acronym for mania? Big fast. And where does speech come in? Talkative. T. Talkative. So don't get fooled, right? Into that. What is it most likely? What does it smell like? So there are components of other diagnoses that stay center mass on this. What's it most smell like? Good. Negative symptoms. What are the negative symptoms here? What is a negative symptom? What's a short definition of a negative psychosis symptom? Apathy. Yep, I don't care. I'm unplugged. What else? What's an objective symptom that you can look at and see? Poor personal hygiene, right? They check down and taking care of themselves too. Say again? Say something?
That was the same.
Yeah, good job. Whatever he said. That's good. Yep. Apathy, flat affect is another one. Diminished emotional expression. You won the lottery. That's right. Avolition, significant or severe lack of motivation or pronounced inability to complete purposeful tasks. Avolition, it's another word for our medical terminology place. Do you think this guy has a job? Probably not. This has been going on for 8 months. Or he probably won't for very long after this. I think it's clinically significant. Yeah, he got arrested, or at least detained, brought to the ER by law enforcement. It's a big deal. Do we have enough criteria for schizophrenia? Plus the time component. Yeah. How about substance abuse? Looking at these symptoms, does this line up with could a substance cause this?
Yes.
Yeah, absolutely.
But the parents could have potentially brought that up.
What don't we have in this question? Substance. Yeah. What's your first question? One of the first questions is going to be, one, do you have a weapon? Two, is there, what's been taken? Has he got anything on his person that would make you think there's a substance involved here? Because if you're able to reverse that with some sort of remedy or antidote, that'd be great, wouldn't it? Not to give him schizophrenia. Hey, quit the drugs, stay at work, be healthy, be good. We don't have that in the question. Good job. Schizophrenic form, we know why is it not schizophrenic form? Too long. Yep. So what's the time frame for schizophrenic form? 6 months back to 1 month. Yeah, 1 month to 6 months. Is that a peak symptom? Measuring a peak symptom or what? Pro and post. So that ramp up and down counts in the whole time component. Good job. There it is. Good job. We flashed these. There's your pictures of the positives. Good job. Good job. There's the pink box. What would we do for this person? What's the number one thing we want to protect or do? Protect the patient. Protect the patients for those who can't protect themselves. They're listening to instruction from a make-believe something. It's telling them to hurt themselves or other people. That's a big deal. So we want to protect them. That's the number one. Safety is what we want to do. And so to do that, what would we do? If this is the first time you saw this guy, what would you do? You look at his med record, or you have no med record, and you see this guy, and this is the first time you know he's being seen for this kind of thing, what would you do? Make sure it's not a tumor. How do you do that? Sir, is this a tumor? What's your opinion? We're all going to vote. Anyway, what'd you do? Take a picture. Yeah, brain imaging. First time presentation with psychosis, brain imaging. First time. Gotta do it. Good. Safety, and then when we get to meds, what are we going to use? Second gen antipsychotic. Good. First time? Right away? We're going to give him meds? How long does that take to kick in? A while. How long is he going to be on it? A while. Yeah. We still going to give it to him? What if it gets better? It's going to be back, probably, right? Odds are that things coming back. So we're going to treat him, SGA, Student Government Association. We'll give him a drink machine in the cafeteria and they'll cure it. Here's what you do. Good safety is number one. Brain imaging, first presentation. Second gen antipsychotic. You go to first. Good job. There's our cheat sheet. Cliff notes for schizophrenia and psychosis disorders, psychotic disorders. All right. Let's change the last part. It's been happening for 3 months. What's the most perfect medication for this patient condition? So did we change the diagnosis when we said 3 months? What did we change it to? Schizophrenic form. What would we do treatment-wise? Same? Even though it takes a long time, schizophrenic form, 6 months. What aren't we? Fortune tellers, right? Can we tell when this is gonna be resolved? No, we can't. So we're gonna treat him for this, because it's most likely gonna be. Good job. Second gen. All right, so which one of these, what is sertraline? SSRI. What kind, just for jollies? Activating, okay. How about midazolam? Benzo. Would we give him a benzo right now? So this is this can be tricky. You think about this, right? So think about, is a benzo for somebody who's unruly in the ER, is that appropriate treatment?
Yes.
Yes. So you got to think about how's he presenting, and 2, what's the question? Is it for acute symptoms, or is it for condition, long-term, chronic? What's the intent of this question, and what's the best answer for this? So benzo could be, all right, we'll think about it. Risperidone. What is risperidone? Which is actually one of the if this guy was 16, what would you think? It's on the list. It's on the rack of my brain list. RAQ. Good. Second gen. So do we like second gen antipsychotic better than midazolam for most appropriate medication for this patient's condition?
Yes.
Okay. It's close. It's probably the 50-50 right there right now. Okay. But in the description, you think about what's being described there. Is it highlighting the unruliness in the ER, or is it highlighting diagnostic criteria for schizophrenic form? Schizophrenic form. Think about the intent. What are they trying to steer me towards? And what could be close but not as good? Lithium. What is lithium? Spawn of Satan, right? Lithium. What is lithium used for? What kind of med is lithium? And it'll help us too. Mood stabilizer. So when we talk about mood, primarily mood gone out of control, in the negative end, mood downer, what is that called? What diagnosis is that? Depression, MDD. Yep, mood going in the other direction, what is that called? Mania. What diagnosis has mania? Bipolar, yep. So do we give lithium for schizophrenic form? Is it a mood thing? No. It's a psychosis thing, it's different. How about haloperidol? All right, here's a hint at medical test taking. When do you consider haloperidol in a patient like this? You watch the benders, you watch them wrestle through in the ER. What's haloperidol primarily for? Hit him with that Haldol. Knock him down. Right? It takes 15 minutes. You're wrestling for 15 minutes-ish. And so is that a similar approach to somebody in this situation, time in the ER, law enforcement, and midazolam? Those are both downers trying to calm them down in the ER, right? Primarily. So you think, man, those sound very similar in what we're treating this patient for right now. It's hard to pick between those two and what we're doing. So you're thinking, if it's too close, it's probably not that. There's a better one, second gen underlying condition. Does that help you? If you give you 2 SSRIs and you're thinking, oh, it's an SSRI without any distinguishing between those, and you think, well, it may not be SSRI because those 2 both are the same equal rightness. Look at something else as being a better answer and a different question. Good job. Risperidone, second gen, you did it. 3 months changing diagnoses, just like you said. There it is on our definitions. Y'all already know that. And then when we get to meds, we safety. If it's the first time, we scan the brain, and then if we need it, we're gonna give them meds so it doesn't happen again. Good. That's quite the lineup. How do you speak hope in the future into these people's lives? point them in the right direction, see about the benefits of their condition. Next question. I give you 10 minutes for a bathroom break? Yeah, 10 minutes. See you 5 minutes. If that projector's been out for a while. Sorry about that. Yeah, I guess the challenge here, you see all these faces, do you see them as broken? And as a provider, you can't wait to tell them how wrong and what's wrong with them? Or do you see potential and how you can help them or point giftings in a certain direction and help them succeed? So that's a mentality that will be challenging to maintain as you're being a provider and practicing. You're 18 patients deep, and then you got female vague belly pain, female fertile, and it's late in the day in the lab and the radiologist is closed, and you're thinking, oh, help them do the best one, protect them. All right, next question. That's my motivational speech. It wasn't very good. All right, question is, most concerning. So there's probably some that are concerning, but what is the most concerning for domestic violence? So we're talking about domestic violence. What fits in domestic violence? We're talking about violence. Interpersonal, yep. Does elder abuse fit in domestic violence? It's a subcategory of, yes. Domestic violence is a big umbrella. Child abuse, elder abuse, interpersonal violence, they all can fit under domestic violence. So think about that. It's a lot of things under this umbrella of domestic violence. So 5-year-old, we got a child, male, second-degree burns on extensive surface of bilateral forearms. Uh-oh, what do we gotta know? What comes to mind? What vision, what slide comes to mind? The chart, right? We gotta know burns, fractures, soft tissue injury, and the age of each one of those, right? How about 5-year-old, second-degree burns, extensor surface, bilateral forearm? Is that concerning?
Yes.
Can be, yeah. All right, let's look and see if we got it better. 22-year-old female, so we got adult, female, childbearing age? Yep. Broken clavicle was accompanied by her spouse to the ER. What do you think about that? We think part of it, we're in psych class and we're talking about domestic violence, and so we're thinking about this husband sitting there answering for her, telling her what to say, and keeping her quiet. He's the predominant one. Are we given that in this?
No.
No. How many times does a spouse accompany someone to the ER? Very fine. In the most instances, is that a good thing?
Yes.
Yeah. Would you want her driving a car with a broken clavicle? No thanks. I want her spouse to be there. So, could be very innocent. Is anything nefarious in that what we're given? It's pretty vanilla. It's pretty good. So don't read into it just because we're in psych class. And he's a creep, right? He could be. We aren't given that, right? 83-year-old male, so there's elderly, male, new flat affect. Uh-oh. What do we know about that? New flat, is that trips and wires? And you go, oh, here we go. What are we talking about? What diagnosis is that? Elder abuse, right? The only one with elder in the word that we talk about is elder abuse, yeah. New flat affect after his caregiver stopped playing spades with him. Okay? So when we talk about physical or emotional abuse, what is that? Emotional abuse. So in domestic violence, is emotional abuse violence? No, it's not. Think about the question that's being asked. Violence, emotional abuse is not violence. Right? So we're looking for something physical here. You get that? You understand where that? Good. 41-year-old male, cage fighter. Adult, male, cage fighter. His name is Kip, with multiple superficial injuries and different stages of healing. Ooh, they're using buzzwords now. different stages of healing. Is that a buzzword? Is that something where you go, different stages of healing?
Explained by itself.
And it's explained. It's a better explanation in that everybody knows I'm trained to be case fine. 41-year-old. Yep. All right, 31-year-old female with frequent somatic complaints and multiple unexplained injuries. Adult, female, childbearing age? Yeah. Frequent somatic complaints. All right, we're crossing lectures here now, right? Somatic, what is that? What's a somatic complaint, somatic symptom? Headache could be one. That's an example of it. What is, help me understand, define for me short, what is somatic symptom?
Pain without a sign. But there's like underlying, there's no physical etiology.
Right. There's a symptom, but it doesn't match up with a diagnosis. Right? So it's somatic, there is something there, but it doesn't match up. So she's got those kind of complaints and multiple unexplained injuries. So it's in addition to, so it's and multiple unexplained injuries, not that those are the somatic complaints, and multiple unexplained injuries. What do we know about abuse? When you see somebody, a lot of times, for things that aren't there, what do you want to ask? What do you suspect? What do you want to at least rule out? Why is she coming to see you? Why does this person come to see you? She's coming for a somatic complaint. Why do you think she's coming to you? What could be a reason she's coming to you? She has multiple unexplained injuries, but she's coming to see you with somatic complaints.
That's not ask, but.
She's giving you the opportunity to ask.
Exactly.
So she's not to rat herself.
Yeah. What common things we cover, statistics being true. Who was doing the abusing here, if there's abuse here? Who's doing the abusing? Somebody that's close to her. And what about when she comes see you? Trying to get away. This could be the only time she gets out of the house. So she wants to get out of the house. Give you a chance to ask about those other unexplained injuries, but she's getting out. She's getting relief. She's getting out of the house. So I kind of hinted at, lean toward, give you a nudge in that direction. Do you like the second degree burns on extensor surfaces of bilateral forearms, or do you like this one, somatic complaints and multiple unexplained injuries? So we have one that says unexplained injuries. We have second degree burns on extensor surface of bilateral. What could that be? What's an innocent explanation of that?
Super bad sunburn.
Sunburn, extensor surfaces. What do we want to pay more attention to? Burns, flexor surfaces, protected areas, groin, right? Extensor surfaces could be sunburn. We just give them a, hey, we forgot the sunscreen. Okay, get some sunscreen. Done. Parent feels bad about it. Frequent somatic complaints and multiple unexplained injuries. When we're talking about most concerning, that's the most concerning. Unexplained or multiple injuries, she's got both. Frequent non-specific somatic complaints, there it is on the slide. Burns to protected areas or an object's pattern. Remember that? If I wasn't wearing my house shoes, stepping on that grate at home, I would have had that on my foot, and my mom would have never forgave herself. She's a great mom. There's the chart, 2 to 3 year olds. And the burns in that one, unexplained burns. So I feel you. Could have been that. As a red flag, it's one that we want to raise our eyebrows about. We're talking about extensor surfaces, less concerning. There's the emotional abuse signs that we talked about with the elderly, stop playing cards. Maybe the old man cheated, right? Quit cheating, old guy, grandpa. Next question. right, what's the question here? What are we asking for? Diagnosis and most likely, so more than one might fit. All right, what lecture are we in when you read this? Okay, I heard somatic could be what? Personality disorder. What's the difference in all the personality disorders? What do we describe those as? What are they? Clusters, correct. 3 clusters, good job. How is a personality disorder described, and what parts of the life does it affect? All areas, pervasive in all different, for a long time, everything is affected by this personality. Think about the intent of this question. Is this adult or child? Adult. Male or female? Female. Childbearing age? Stable or unstable? Stable for the most part, right? We're kind of talking about past events, or it's not really something that we need to call a code for. But what's going on here? What are some pertinent positive negatives you want to point out? Are depressed, suicidal, what?
Fear of being alone.
Fear of being alone. Ooh. When you think about personality disorders, which one do you think of when you think about that? Fear of being alone. Dramatic. Yes, cluster B. Yep, being closer.
Dependent.
Dependent. Okay. Fear of being alone. Dependent personality disorder. Good. What other one?
Borderline.
Borderline personality disorder. Any others? Is dependent in cluster B. Dramatic. Sometimes it may come across as that, but no, it's in C. It's perfect, right? Okay. Let's look at these and see if we can't work through it and get there. Depressed, suicidal. If they say suicidal, what do we want to make sure before we discharge this patient? Doesn't have a plan, not a danger to themselves or other people. What if they want to leave, but we think they're a danger to themselves or don't know them?
Lock them up for 72 hours.
Can we lock them up? Is that okay? It's not comfortable, but we are within our authority to do that, 72 hours, to determine whether they're a danger to themselves or other people. Good. It's called different things in different states. All right, first one, post-traumatic stress disorder. What do you think of when you're trying to diagnose PTSD? Trauma has to be first. What do I think about whenever I'm just combining into my thought process? The train, yeah. All aboard the PTSD train. What kind of train is this? What's the number on this train? 12, 1, 12. Exactly. 12, 1, 12. What's the middle one? What's the one for in the middle? 1 month. Yeah. All right. What's the train? What's the TRAIN? What's that mean? T, you already got the trauma. Good. Traumatic event. Is that your definition of trauma or the patient's definition of trauma? The patient's, right? Trauma or the threat of a trauma. Good. What's R? Reactivity. What's an example of that? Yeah. Startled easily. More than out of proportion to. Do we see the startledness in this person? One, do we see a trauma? Stormy relationships could be, right? Could be traumatic. Okay, I'll give you that. I'll put that on there as potential. Okay, T trauma. Reactivity. Do we see startled, easily startled? Reactivity. Whoa. No, I don't need it. We need 2 of those, right? Because it's 12. It's 2. R is 2. And then what's the A? Avoidance. What does that look like? Avoidance of what?
The trauma.
Of the trauma. Yeah. That would remind her of that. So if the stormy relationship is a trauma, then she might avoid entering into another. That's a good point. Yeah. Okay. Invasive thoughts, the I. I gave you that one. TRAI. What's an invasive thought? There's a famous word, tagline that's associated with PTSD with this one. You heard it? Flashback. Flashback. Or what else? What's another intrusive thought? Maybe not when you're conscious. Nightmares, right? That's an intrusive, unwanted thought that comes back. Flashback or nightmares, that counts in intrusive thoughts. Do we see that? Flashbacks or nightmares? Yeah, nope. How about end of train? What's that one? Negative, cognition, and mood. Do we see that? Yeah, more, a little more than kind of. What is it? We're given it. We're said that they say the word. Go up to the top. Depressed. Boom. Got it. But do we have enough for PTSD? It's pretty loose. All right, let's look at the second one. Borderline personality. What face do you, who's your poster child for borderline personality? Brandon Marshall. NFL fan. Appreciate it. Anybody else fits the borderline? Because y'all, not everybody knows who Brandon Marshall is, okay? Lindsay Lohan, yeah. Who else? Pete Davidson, yeah. Borderline. Drama. And what, now, when we're talking about difference, we're talking about what's close to borderline. What's another personality close to borderline? Histrionic. And what's common? They have a common thing, but they use it for different purposes. Sexuality. What does borderline personality use their sexuality to do? To not be alone. To avoid being abandoned. What does histrionic personality sort of use their sexuality to do? Be the center of attention, right? Feel Puerto Rican. Yeah. Be in the middle. They use their sexuality to be in the middle, to be the center of attention. Good. All right, so do we like borderline personality? Is there a pervasive pattern instability of interpersonal relationships beginning by early childhood? We have several stormy relationships, so maybe. Okay. How about frantic efforts to avoid abandonment? Does that fit this person? Does it feel like it fits? Yeah. How about impulsivity in 2 or more areas? What would you say those are? Illicit drugs, stormy relationships, irritability, okay? Chronic feelings of emptiness. She told you, feeling empty and void. How about intense difficulty to control anger? Several stormy relationships, yeah. Fit, so see if there's a better answer. See, Charlie, schizotypal personalities. Who is a schizotypal? Who do you think of? What's your poster child for schizotypal? Say again? Close. Starts with saying that's schizoid. I like your Tesla. That's schizoid. How about schizotypal? Remember the 2 guys? You got the emo team, the schizoid, and the other guy's schizotypal. Dirty hippie? Yep. Willy Wonka. Crazy uncle with a toast in his pockets for good luck. Knows the lottery numbers, but hadn't won it himself. Mystical, magical thinking. They're a mile wide and an inch deep. Everybody knows them, but nobody really knows them. Narrow emotion to be able to express that. That's schizotypal. Professor Trelawney. Tea leaves, right? Willy Wonka, good job. How about narcissistic personality? Who's your poster child for that? A lot of self-awareness if you say yourself, but I'm not saying that. Say again, Gaston? Yes, exactly. He loves him some him. Right? I don't pick on Terrell Owens, but first thing in the NFL receiver, he loves him some him. He does. Narcissistic, what was our videos? Remember our videos? don't know how to say this, but
Oh.
I'm kind of a big deal. Yep, or I am the world's best boss. Right? I found this at Spencer Gibbs. He bought the mug for himself. So that's fun. Good, Gaston, Uncle Rico. Narcissistic. Do you think this patient fits narcissistic? No. How about conversion disorder? What is conversion disorder? What are we converting? Yes, traumatized physical symptom or psychological event. So can we trace back to a psychological event with this person? Is there room for that to be something in the past that was a psychological event? What? Yes, I agree. What? Stormy relationships could be that. Good. Now, what is the disorder piece? What happened? What lecture are we in with conversion disorder? Somatic lecture. Okay. So if it's under somatic disorders, what has to be present? Somatic symptom. Yeah. Yes. How would we say that in an inclusive way? What kind of symptom would be present? Voluntary. Sensory motor. Voluntary sensory motor. That's something where a traumatic event or psychological event has been converted into symptoms that are voluntary sensory motor. Somatic symptoms. So it doesn't match a diagnosis, but it started or it can be traced back to that psychological event. Does this person have somatic symptoms? In particular, voluntary sensory motor somatic symptoms. No. Something where she can't speak, or can't move her arm, or can't walk. Remember Ricky Bobby with the knife? Since the wreck, I can't walk. No, you're fine. I can't walk. Oh, I think I'm fine. So which one you like the best? Borderline, good job. There it is, dramatic. Y'all nailed it. Cluster B, dramatic. Borderline personality. There's all the things ticked off that are in that question. There's our pink box. A lot of things on that pink box in that question. There's our poster child, Amy Winehouse, in that lineup as well. Dramatic. Borderline personality. Silver Linings Playbook. I forget her name. The girl. The girl's name. You say more inappropriate things than appropriate things. Yeah. Come on. Hot mess. There's our borderline personality. Tiffany, that's it. Silver Line Play, played by Jennifer Lawrence. Anakin Skywalker, Norma Jean Mortensen. Borderline treatment, what do we do for it? Positive peer pressure. Operant and aversive, right? Reward versus punishment. They get a buy-in and they impose that on themselves. Get them buy-in so they can motivate themselves through these rewards. If I do this for this long, I get this reward, or if I don't, then I have a punishment. Not crazy, but I don't get to eat my Reese's for today. Psychotherapy, put them in group therapy, individual therapy, that positive peer pressure. And then looking at that list of meds, antidepressants, if that, looking at her symptoms, she could use that, right? Because of her depression, suicidal. She has some aggressive behavior, impulsiveness with stormy relationships, some hostility and agitation for sure, and then behavioral discontrol. Could be in the lineup we give this person. So you look at what could most benefit, indications, risk, benefit, alternatives. There's where we employ pharmacologic with personality disorders. And we don't do it alone, we get a treatment team together. Next question. All right, this one's pretty straightforward. What would you say? Knee-jerk reaction. We may buy some more time with it. Just say this 60 seconds for another question. Illness, anxiety, which is formerly known as hypochondriacs. Yes, you don't know, you don't need to know formerly known as, only if it helps you remember illness, anxiety. So give me that in your own words. Illness, anxiety disorder, what is that? Concerned about one day developing a what? Serious illness. Yep. Yep. Do they have symptoms? No, or very low. No symptoms or very low. Good. Overwhelming. May one day. Good. What's generalized anxiety? All the things. Worried about all the things. Yep. Is this about multiple things? Is this patient worried about multiple things? It's a very serious. Good. One thing. How about somatic symptom disorder? What do you have to be a somatic symptom disorder? Symptoms. Right. This one, is there any evidence there are symptoms in this question? Nope, can't be that. Illness, anxiety, we like it. How about conversion disorder? What do you need? A symptom, what kind of symptom for conversion disorder? Voluntary, sensory, motor. Yep. Trace back to a psychological event. Something happened. And then that's when the symptoms started after that. Do we have a symptom? No. Anxiety disorder. Do we have anxiety here? Overwhelming concern, yep. Due to another medical condition. What don't we have? We don't have we don't have a medical condition. We have worry is the only thing about a future baby. Good job. There it is. What do we do first for this one? CBT. Couldn't get it through this class without saying that, right? CBT. Same treatment approach as somatic symptom disorder. Set healthy boundaries. This is the one that can wear you out. Set healthy boundaries, have a rule, give them the plan, follow up, keep them accountable, but be kind. Be kind to them. Come alongside them, but hold them accountable. Good job. Don't give them meds just to avoid an appointment with them. Next question. All right, what's the question? Diagnosis and most likely, so more than one might fit. Is this a child or adult? Adult, male or female? Female. Childbearing age? Yep, stable or unstable? Stable, right? Why is she there? Loss of voluntary movement of upper extremity. All right, what did we just talk about? What comes up to your mind right now? They said the word voluntary. What else did we just talk about voluntary? Yep. Describe the symptom that we need for conversion order. Voluntary, sensory, motor. Yep. Trace back to a psychological event. Is there a psychological event here?
Yes.
Yeah. Separated from her husband 2 weeks ago. Yeah. Now what's the rest of that stem telling you? It's telling you what she's coming in with doesn't match up, right? Everything you're seeing on exam says you should be able to use that. Should be okay. So it's telling you this is somatic symptoms that she's presenting with, right? And then what else did they do for you? If this is the first time she presented, what do we need to do? MRI, brain scan, make sure it's not up here. They did that, normal. Nice. And cervical spine to tell you where do the nerves that control the arm come off. Cervical spine, brachial plexus into the arm, 5, 6, 7, right? You got that, right? Okay, feet, y'all are male. Good job. So what would you call it? Somatic symptom disorder. Is this somatic symptom disorder? Echo, we go backwards, echo. Is this somatic symptom disorder? Yes, it is. That's our best answer so far. Yes, it is. Right? Let's see if there's a better. Illness, anxiety disorder. Is there a concern about future with no or very minimal symptoms today? She's got symptoms, right? Even if we don't believe her, the patient and what the question says, it doesn't give us any indication she's lying. So there are symptoms present, so it can be illness examined. How about factitious disorder? What do you need with factitious disorder? In a medical question especially. Proof of factitious. What is factitious? Truth telling? Lying. Somebody's lying to you. So you have to have evidence of lying in the question. Do we have evidence that they're lying to you? Supervisor comes with them and says, I want this airman to apologize to you for wasting your time. Don't have it. How about conversion disorder? Like that one, based on what we said so far? Voluntary sensory motor, trace back to psychological event? Yeah. How about delusional disorder? Is there a fixed false belief despite evidence to the contrary? Is there a fixed false belief? Do you have a lot of evidence to show this patient to say, look, you're okay? The answer is yes. There's delusion here. Could be, maybe, right? A fixed false belief despite evidence to the contrary. Okay, there's delusional disorder. Can she actually move her arm? Seemingly, based on what we're given, no. But we're sitting there going, come on, let's move your arm. Let's stab you with, no, don't stab me. Let's do the Ricky Bobby. Don't do that. Is the test writer pointing you in the direction of falsifying her symptoms? No, he's not telling you, look, she's lying to you. That's not the direction of the question, is it? The intent of the question is to convey you the genuine nature of the patient's claims and an extensive negative medical work. So it might fit, but is there a better answer? This one's tight. Which one do you like the best? Delusional disorder, conversion disorder, somatic symptom disorder? Conversion disorder. So there are three possibly correct answers here, but the most likely, the best answer, conversion disorder. It fits the tightest. There's a psychological event, trace it back to symptoms that ensued from that are voluntary sensory motor, and there's no evidence there of falsification, so that one fits the best. Could the other ones? Yeah, but we're doing a little mental gymnastics to get there. There it is. Conversion disorder. And you're thinking, really? This is a retired pains question. That's what that tiny little writing there that you got on your slides, you can zoom in and read. Don't hate the player, hate the game, right? I'm trying to give you a taste of what you're going to get on the next level, and you think, man, that question, I don't like it. That one's too tight. That's what we're getting you ready for, and one day, you're going to get there, and you're going to be able to parse that out and answer that question. There's a conversion disorder from the pink box. There's our poster child, Ricky Bobby. There it is again. And there's a treatment disorder. Sorry, what we do for it. Refer them to PT, get them moving, CBT, work with them. It's going to be a slow process. You treat the underlying psychological event back in the day, but also hands-on and help them, maybe some EMG and stim to get those muscles working for them to feel that. But PT is a big presence in this as well. Be professional, be genuine. Don't act like they're wasting your time. It's real to them. They're coming to see you. It's real. Meds rarely know. So don't just throw meds at them. Next question. All right, what's the question? Diagnosis, most likely, so there's probably more than one that could work. We want the most likely. Is this adult or child? Adult, male or female? Female, childbearing age? Stable or unstable? Close. Close, right? Where are we? Emergency room, so our eyebrows are up. So we don't know. This is kind of borderline. Why is she here? Dizziness, tremor, diaphoresis, shortness of breath. What are differentials? What do you come up, if you're in the ED and you see this, what should be on your mind? Heart attack, MI. What else? Panic attack, okay. Is panic attack life-threatening? All right, what should we address first? Things that could kill them, including themselves. PE, like it. What else? Allergic reaction, love it. Anaphylaxis, yeah. What else could cause sweating, shortness of breath? Second. Diabetic, decay, yeah. Yeah. Low glucose. Do a finger side, bedside finger stick, see where glucose is. Exactly, love it. What else? Hypoxia, okay. Yeah, not enough oxygen. Yeah. What could be causing that? Sorry, didn't hear.
I said altitude sickness or choking.
Altitude sickness, choking. Love it, yes. Put that on Jeffrey. The point is there's a lot of things that be causing this, right? A lot of things, just keep reading. So when you see a patient, you want to think about what's going to kill this patient. Do I need to intervene right now? And if not, okay, then I can slow roll it and start going down my list. But we want to say, can they breathe? Is their heart pumping? Right? ACLS, we want to go there. What's going to kill them? I need to go there first. If reports coming to hospital with similar complaints twice in the past 6 weeks, what does that make you do? What does that make you think of right there? As far as stable, unstable, what do you think of there? Less concerning if this has happened twice in 6 weeks and she's still walkie-talkie. She's telling you the story. So if this is an MI, and this is the third one in the last 6 weeks, less likely, okay? So our DEFCON is lowering a little bit, but still, those are still concerning, so just keep reading. On those occasions, as today, physical exam, routine labs, ECG, EKG, and cardiac enzymes, apart from the reported symptoms they observed, have been unremarkable. What does that tell you? I know we hadn't studied cardio or any of that. Any medics in here, when you look at EKG and cardiac enzymes, what does that rule out? MI. You're not having a heart attack. Whew, okay, good. That's a pretty definitive answer right there for you. And I know we're not there yet. And I'm not asking you to read this, but it's giving you a list of a lot of things and it says unremarkable. And you can say, all right, I see cardiac in there. I see physical exam. All that's unremarkable. What is that telling you? Stable, we're getting closer to stable. Yep. First rule of Psych. Rule out organic ideology. So that's what we're working towards. And that you see the intent of the question is pushing you in that direction. You were worried when you first saw that first line, as was I. And now we're getting down there and okay, I'm lowering the DEFCON. My eyebrows are slowly returning to their original state as we're getting through this question. The patient states that these episodes are starting to concern her greatly. Okay? And she's worried about going out of her house alone. Now what ology are we in? Psych. Here we go. There we go. Now we're talking about worry, concern. Great. Out of her house alone. Out of her house alone. What does that sound like? Social phobia. Okay. What is a social anxiety disorder? What's the key component of that? Being judged by the scrutiny of others. What is going out of your house alone? Because there's no indication that there's anybody else there. What's that? There's another agoraphobia, right? Being in a controlled environment, crowded space, or wide open, where you can't get help. Agoraphobia, maybe there. We'll put that on our differential. How about episodes starting concern or greater? What are those symptoms at the top? What is that? Like you said it earlier. Panic attack. You think this looks like a panic attack?
Yeah.
Yeah. That sounds like a panic attack. Could fit. If we jump there first, and they die from an MI, we say, oh, misdiagnosed. That's not a good answer. We want to go to MI first and rule it out, and then we look at panic attack. Right? So you get the $1 million workout, and then we say it's a panic attack. When she says twice in the past 6 weeks, that doesn't automatically, or we don't do cardiac enzymes, EKG, and ED. We still do that. We still rule out big, bad, ugly, because crazy people get sick too, right? Knuckleheads still get sick. So we do our due diligence. What goes through the wickets, whatever could kill them, we want to rule that out. But then we get down to, all right, taking that off the table, worried about, concerning her greatly, episodes of. When you have episodes that look like a panic attack and you're concerned about getting it again, what does that sound like? A disorder. What kind of disorder? Panic disorder. Yeah, sounds like panic disorder. Okay. Falling most likely disorder. Someone get in there, there's panic disorder on it. Hey, it's in the list. I like that. There's the whole thing's written. That's right, that's good. We just talked about. Good. All right, let's go down the list and see if we can review and rule out. Factitious disorder. What do we need for factitious disorder? Lie. Lie to me. Right. Falsification of illness. Is there any indication that she's lying to you? Nope. Seems pretty straightforward. What? Generalized anxiety. Multiple things. Excessive worry about multiple things. Is there multiple things in here she's worried about? Doesn't seem like it. Not getting panic attacks, going out of her house. A couple things. Well, not a lot, not everything, not indiscriminate worry. Or how about panic attack? Reoccurring unexpected attacks. Doesn't tell us that they were expected. Yep. Sudden onset. 4 or more symptoms. Dizziness, shaking, sweating, shortness of breath. Obvious cause or trigger. I don't see an obvious cause or trigger. Deep. 1 month of worrying about having another attack. How long has it been? 6 weeks. We have our time component. So that sounds like it fits. See if there's a better. Schizophrenia. Is there a positive psychosis? Hallucination, delusion, fixed false belief, sensory impression without stimulus, disorganized speech. I don't see any of that, do you? Has it been 6 months or more? No, 6 weeks. Okay, not schizophrenia. Social phobia. What's a social phobia? Being in a social situation. Is there any indication there's a social situation? Nope. Good job. Panic disorder. And another retired parents question. There it is, panic disorder. Y'all nailed it. We're going through it and you're saying, I got it. There's a pink box, more pink box. What do we do for panic disorder? CBT. Good. Woosah, relaxation. Good. What do we do if we get the meds? Muhammad Ali. Muhammad Ali, yes, that's right, antidepressant, any antidepressant package disorder, so you choose choice. They're in order of preference, in the med slides as well. If you have the option to go with Muhammad Ali, SSRI before TCA, that makes sense though. There's no contraindication. Good. All right, next question. Y'all welcome to go. I'm gonna keep going because we only got a couple more left. We're gonna press through and be done. All the best. I'll see y'all on Friday. I'll hang out. I'll be here the rest of the week.